Good afternoon, everyone. Welcome to our webinar this afternoon on education on newly diagnosed myeloma and what to expect. This is part of our educational info webinar series. This presentation was part of our national conference, which by now you already know has been postponed for this year. My name is Gabriele Colasurdo. I'm the manager of education patient services for Myeloma Canada. Um, and before we get to our presentation, just want to go over a few things with you. So these webinars would not be possible without our sponsors. So thank you to Amgen, Binding Site, BMS, Janssen, and Takeda for providing support so that we can do these. So as I mentioned, our educational info webinar series, and so we've ramped up the amount of webinars we're doing due to the COVID-19 pandemic to replace our live events. You can see here a list of our upcoming info webinars in English. There's some in French as well for those who are interested. That's all available on our website. And so with that, the next webinar is on Thursday, May 7th at 1 p.m. So same time like this one. We have the Myeloma Canada Patient Advisory Council who will be you'll basically get to know them and learn a little bit about them and how you can collaborate with them. All of our webinars are recorded and they're available on our YouTube channel. So if you go to youtube.com and type in Myeloma Canada in the search bar and click on search, one of the first links you'll see is going to be Myeloma Canada. You can click on this subscribe button right here, and that'll give you a notification every time we add a new video. That way you'll stay up to date whenever there's something new. From our website, you can also get to our recordings, myeloma.ca. Click on the resources button here on the menu. It'll take you to a drop-down menu will come down. You click on educational videos, and you'll be able to go to YouTube that way. How do you ask questions? So for this webinar, all of your questions, you can type them into me. I will receive them and I will ask our presenters today the questions at the end of the webinar. So how do you ask a question? On your GoToWebinar panel, so this is if you're using a computer, you'll see questions, a little triangle here. When you click this little triangle here, this box will kind of open up right here, and you can type your question here and then press on send. As I mentioned, I'll receive those and be happy to share them with our presenters. So without further ado, I'd like to introduce you all to Dr. Hira Mian, who's a hematologist at the Juravinski Cancer Center, as well as an assistant professor at McMaster University in Hamilton, as well as Wendy Bursey, who's a primary care nurse in hematology, also at the Juravinski Cancer Center in Hamilton, Ontario. Dr. Mian?
Perfect. Thanks, Gabriel, for that introduction. And we're really excited to present this topic of newly diagnosed myeloma and what to expect, both on behalf of myself and Wendy. And we both help take care of patients at the Juravinski Cancer Center in Hamilton. So newly diagnosed myeloma, some of you may have already been diagnosed with it recently or have family members who were recently diagnosed with it. And it's probably a day that's hard to forget with all sorts of information that came from every angle in terms of what's the chemo like, what's the genetics like, what's the bone marrow, what are the stem cells. And so part of what today is about is just slowing down and going over some of that information. Some of this may be information you've already heard, or it may be new to you, but today we're just going to slow down, take things from the beginning, and hopefully help you navigate this really difficult journey and make some things a little bit easier. So I'm happy to, again, take questions at the end, and we really want to make sure that we get to what you guys want to know from this topic. So we'll start off with some basics, and then we'll go over some treatment, and then some practical things around myeloma. So multiple myeloma is really a rare cancer. It's the second most common blood cancers, but if you look across all new cancer cases in 2019, it really only represented about 2% of it. It's considered a cancer of older adults, with the approximately median age being about 70 years. There's, a slightly higher preponderance of males. Ethnicities are affected differently. And with regards to the life expectancy of myeloma, and really I don't particularly like the number that's over there, as I'm sure you don't either, but that's a life expectancy from the year 2000. So with myeloma, there's been drastic improvements in treatment really over the last decade, and particularly over the last 2 to 3 years, multiple novel drugs have entered into this space. And so it's with a lot of optimism now that we think about myeloma and the treatment for myeloma. And so although back in the year 2000, the average lifespan was 3 to 5 years, when patients ask me right now, my answer is I really don't know because things are changing so rapidly in the field of myeloma. I think the one thing that still remains is that myeloma is an incurable malignancy. And to this point, we've found no cure for it, but certainly there's been a lot of research interest looking into that. So, really, the treatment for myeloma, there's a lot of optimism around that over the next decade. So how do you get multiple myeloma and where does it really come from? So multiple myeloma can occur from some precancerous stages, and that can be from what's called MGUS, which is monoclonal gammopathy of undetermined significance, or smoldering myeloma, which all eventually turn into this disease called multiple myeloma. Now, some of you may have been diagnosed during these periods and then had follow-up until you turned into myeloma, and some of you may have been discovered here. As it remains currently, when you have MGUS or smoldering myeloma, apart from follow-up and outside of clinical trials, there's no real treatment for this. So having been diagnosed at an earlier stage, it's hard to know what difference that would have made currently, because really we only intervene as of right now when you have overt multiple myeloma. And again, getting back to some basics, and again, some of these are words you already know, but I want to just clarify them. Bone marrow, you either have had one or know someone who's had one. And so bone marrow is a spongy tissue that's inside your bones. That's where all of the blood cells in your body are made. So your red blood cells, which give you energy, your platelets, which help you clot, and your white blood cells, which help you fight infections. And it's really inside that space where all of those cells are made. Another terminology that you've probably heard of is called a plasma cell. And so a plasma cell, myeloma cell, they're all, lots of different words often used to describe the same thing. So most people have plasma cells. In fact, all people have normal plasma cells in their bone marrow, and they are part of a normal response to fight infections. Myeloma occurs when one of these plasma cells that looks like this just turns cancerous, and by that I mean it just starts duplicating and takes over the entire bone marrow. And what this plasma cell does is it produces a immunoglobulin, and we'll go over that in the subsequent few slides, called the M protein or a light chain. It produces a substance which causes all of the morbidity that we see with patients with myeloma. So as I mentioned, myeloma cells, they produce this type of M protein, which is often called a monoclonal protein, a paraprotein, or an M spike, again, all referring to the same thing, but just different words being used for it. And what that M protein does is it causes a number of different health-related problems. And some of you may already experienced them. So sometimes patients with myeloma will present with a high calcium level. Patients who have what we call light chain disease, which is a small part of that M protein, sometimes can clog up the kidneys, and patients may present with renal failure or even on dialysis. Low hemoglobin is, again, often something that occurs in myeloma because those abnormal plasma cells take over the entire bone marrow and prevent other cells from being produced. Plasma cells can also cause bone pain and fractures, and that's really one of the complications we worry about the most. Some of you may have presented with fractures, and part of what we're trying to do with treatment of myeloma is prevent further events from happening. Recurrent or frequent infections, again, can also happen initially when patients are diagnosed with myeloma, because a lot of the M proteins or those immunoglobulins that you're producing are defective and don't actually help you fight infections. Patients often will talk about fatigue and weakness, and some may also have some weight loss associated. So with regards to the next part, which is this type of M protein. So this is that myeloma protein, and different people have different types of M protein. So the M protein is this Y-shaped molecule that those plasma cells are producing, and they're secreting it. It's the same one, they're secreting it again and again. Usually our body will secrete different types of this, and they actually help us fight infection. But the plasma cell, which has become a myeloma cell, produces just one type of it, and that's what we end up measuring in the blood. Now, different people, like I said, will have different types of it, and that's what blood tests help us determine. And some patients, in fact, don't have the entire M protein. They may only have small light chains, which they secrete out. And some patients may actually secrete out nothing, or they secrete out such a small portion of it that our conventional assays don't pick it up. But again, that's far and few in between. Most patients with myeloma will have this M protein that we're able to detect in your blood. And how are we able to detect that? So often that's detected through, again, these are fancy words and they refer just to blood tests, serum protein electrophoresis and immunofixation, or through the urine. And what happens is we take a look at all proteins that are usually produced and then stain them. Again, that's done by the laboratory. And then we see whether one of the types of protein is being produced much more disproportionately. So sometimes that will be an IgG, sometimes an IgA, sometimes light chains. And I don't want you to worry too much about the specific subtypes of it, but just to know that there's different ways that different patients' myeloma will be detected. And so, when you're talking to other people and other patients with myeloma, just realize that this is a heterogeneous disease and the detection process of it may be different. So how is the diagnosis of myeloma made? And again, some of you are well aware of how it's made because of the experience you've gone through. So a bone marrow biopsy or some form of a biopsy, unfortunately, is pivotal to making the diagnosis of myeloma because really it's in that bone marrow where the abnormal plasma cells are found and created and where they're really causing all of the trouble. So at diagnosis, we usually need to do a bone marrow aspirate and biopsy because we want to send it off for the genetics as well as count the number of plasma cells that are in there. But having just plasma cells alone by themselves is not enough to call you multiple myeloma. Now, if you just have the plasma cells in the bone marrow, you may be one of those earlier precursor states called an MGUS or smoldering myeloma that I talked about earlier. But to become a patient with multiple myeloma that requires treatment, you do need an additional criteria as well. So in the past, it used to be just one of the CRAB features, and I'm going to talk about the CRAB features on the subsequent slide. But more recently, having just lots of plasma cells in the bone marrow. So if we look under the microscope and your bone marrow is entirely covered with more than 60% of the cells being plasma cells, then that's enough for us to say, okay, this person needs treatment. Having an involved or uninvolved light chain ratio that's really, really high, and we're really worried that it's going to lead to subsequent kidney damage, is enough for us to now go ahead and treat you. And then having advanced imaging findings is also enough for us to treat you. So really, to make a diagnosis of myeloma, you need at least a bone marrow and then one of the myeloma defining criteria. The CRAB criteria, which I showed you on the previous slide, are really the most common criteria that patients present with. So some patients present with a high calcium level, kidney damage, a low hemoglobin, and unfortunately, bone lesions, including fractures. When we think about myeloma, we've made a diagnosis of it, and then comes about the prognostication part of it. So as I mentioned, myeloma is a really heterogeneous disease. And how do we decide how patients are going to do with it? So over the years, there's been a number of different prognostic markers for myeloma. The one that we most currently use is called the Revised International Staging System. And it relies on your albumin, which is again a blood test, this fancy test called serum beta 2 microglobulin, which again is a blood test, your cytogenetics, which we get from the actual bone marrow sample, and an LDH, which again is a blood test. So all of these are measured initially at diagnosis prior to getting any treatment, and with that we put you into stage 1, 2, or 3. Now, a lot of patients, right up front want to know what their what their staging is. But just remember that some of these tests, like the cytogenetics, may actually take a few weeks to come back. And so it's not often possible to tell you right up front what your stage is. And I mean, I'm going to talk about this point later on as well. But a lot of these staging systems, they were developed prior to a lot of these novel drugs for myeloma. And so right now in this conventional area, it's hard to know what the prognosis of myeloma is just because of the therapeutic uh, landscape of the field changing so quickly. But some of the high-risk genetic markers that we measure include translocation 414, 1416, and 17p, and I'm going to come back to this point later on as well. So these are the cytogenetic markers that I talked about at diagnosis. And again, these are some of the most important prognostic markers that we think are for myeloma. And they often involve what we call translocation. So you have a chromosome, which a part of it joins onto something else and a part of it joins onto something else. Or you may have a deletion where a part of that arm is missing, or you may gain one or lose one. Now, there's a lot of different markers, and conventionally, the ones we often will measure are the ones that are in that revised ISS staging system, which include 414, 1416, 1420, or 17p. There's certain institutions that are able to look at chromosomal 1 abnormalities as well, but most labs will be able to do this basic cytogenetic panel for you, again, because it helps us prognosticate you in that revised ISS staging system. So, you've had your bone marrow, the cytogenetic sample has been sent off, and now we're waiting to figure out what types of drugs and therapy will you get for your myeloma. So in multiple myeloma, when we think of drug therapies, there's actually a number of different classes. So you can have corticosteroids, which is really steroids and form the backbone of a lot of myeloma regimens, include dexamethasone and prednisone, and these are usually given orally. Then you have something called alkylating agents, and they include melphalan or cyclophosphamide, which again are mostly oral pills, and they again are often used in combination with other drugs. These are some of the old drugs that we still use and are still good, but what we do is often now combine them with what we called novel drugs. And so the novel drugs, for the most part, include three categories. They include the immunomodulatory drugs, which one of them is called lenalidomide. And just to make things more confusing, a lot of them have additional names like Revlimid, or pomalidomide is called Pomalyst. So there's the generic and the brand name. And again, these are oral drugs that most patients will take either as part of their upfront therapy or relapse therapy or after a transplant on a different schedule. A lot of these drugs may have similar side effects, but some of the side effects will be different, and that allows us to really tailor it to your specific case. Proteasome inhibitors are the next big category of myeloma drugs. So bortezomib or Velcade, and again, I apologize because all of them have multiple names, which just causes more confusion, is a drug that's given most commonly subcutaneously. So it often still means you have to come into the hospital. It doesn't take quite long, but it does require a chemo daycare visit. And again, that's a backbone of a lot of regimens. And once we get to talking about things later down, we'll talk about some of the side effects. Kyprolis or carfilzomib is another drug, and again, some of these are newer drugs, which is an IV drug, which is given to patients with relapsed myeloma that again has a specific toxicity profile. So we really need to make sure that you'd be the right candidate for it prior to considering. Ixazomib is a drug that's again part of the same family, an oral drug in a different profile. And then I think that the new kid on the block, the monoclonal antibodies, for which right now we have one, daratumumab, is an IV drug which has really changed the landscape of myeloma and has given us response rates and really a treatment duration that we would have never previously expected from any myeloma regimen. So it's definitely been a huge thing to have access to this drug in Canada. So as we think about treatment for myeloma, what we're trying to do is combining different classes, switching around classes at relapse, and then also picking the drug within each class that will really be tailored to improve the efficacy, so improve how patients do on it with minimizing the toxicity. So when we originally see a patient for newly diagnosed myeloma, so you've come in, initially you thought you had myeloma because your family doctor referred you, you had a workup done, which included a bone marrow, the cytogenetics are still pending, we don't quite know what your stage is, and you've had either one of the CRAB features or abnormal light chain ratio or a high plasma cell burden, or your MRI was abnormal. And a decision has been made that, you know what, we really need to go ahead and treat you for myeloma. So the treatment for myeloma is being given because we want to prevent further morbidity and mortality from happening down the road, which means that we want to prevent patients from having low hemoglobin, having fractures, having kidney failure. So we really need to intervene now. The treatment of myeloma, again, is not meant to cure you and for it to go away forever, but we're hoping that with treatment we can ensure that you have a good quality of life and that the myeloma goes into remission. So one of the pivotal steps in the treatment decision making is whether or not you're going to be a transplant candidate or a non-transplant candidate. And this ASCT, that's what it stands for. One second. So in terms of myeloma treatment, so with regards to transplant, if a patient's transplant eligible, we will often, the patients will go through CyBOR de-induction, followed by stem cell mobilization, and then a stem cell transplant and some form of maintenance treatment. For transplant ineligible patients, there's a number of drugs that are often given for either a fixed duration or for continuous or with continuous therapy. And we're going to talk about a lot of them in more detail. So again, the goals of treatment are really to achieve the best quality and depth of remission, improve the quality of life, and to really minimize any adverse side effects. And as much as possible, we really try to see if patients are appropriate for transplant, but obviously having major comorbidities and some other factors may make you transplant ineligible. And so again, as I mentioned, when we're thinking of treatment, so again, sure, transplant versus non-transplant is one big distinction, but then there's lots of other factors that need to be correlated as well. So we need to take a look at your age, your comorbidities, if patients are coming into us with prior neuropathy, cardiac dysfunction, that may affect what type of drug I can use, what the functional and frailty status is, and more we're increasingly becoming aware that myeloma really is a heterogeneous disease and affects different patients differently. So understanding what their baseline functional status is really essential in ensuring that we're using the right treatments that minimize toxicity but give you the most advantage in terms of your disease control. The Patient preference and personal treatment goals are one part that I would really like to emphasize, because I think, as we're making decisions quickly in clinics, and we're seeing lots of patients, and we're often in a rush. This is where we really need to sit down, and you really need to sit down with your oncologist as well, and need to make sure that your treatment plan aligns with what you want your personal treatment goals to be and what your preferences are. So sometimes it's not always possible to align them, but I do think it always requires a conversation. So whether, not coming into hospital is really important to you, or not, minimizing side effects or minimizing blood tests. Some of those things are, I think, do require conversation with the primary care team. Then there's additional disease factors, which, again, the stage of it, the cytogenetic abnormalities, and if you have any concurrent comorbidities. Treatment factors are also, again, a big one, because they don't only affect our treatment decision up front, but also when patients relapse, have they had side effects, what type of reimbursement that we have. And to be honest, in Canada, we do have access to fantastic myeloma drugs. So I think in that sense, we're extremely lucky that we have a lot of great drugs for myeloma that a lot of other places in the world don't have, and that for the most part, they don't cost the patient anything. All right, so we're going to talk a little bit more about this treatment for newly diagnosed myeloma. So as I mentioned, we're going down this pathway, and in each point we're considering whether or not a clinical trial is available. So I'm going to talk a little bit more about stem cell transplant, and there's actually an entirely separate talk on stem cell transplant. But just to know, most of the patients receive 4 to 6 cycles, and each cycle is about 4 weeks of what we call Cyborg D induction. Now, Cyborg D induction includes cyclophosphamide, that's in that group with the alkylating agents, bortezomib, which is a subcutaneous injection, and dexamethasone. And most of this is given to you weekly for a number of cycles, and we hope that you have some form of a response to this, in that the M protein or those light chains come down. Once a physician's happy that you've had a response, and things then get in motion for this entire big plan. So your own cells are collected, and then you undergo a transplant with high dose chemotherapy, and the stem cells are put back in. Now, some patients may undergo one transplant, and in very certain cases, a tandem transplant is considered, where we do 2 transplants back to back in a span of about 6 months. Once the transplant and all of this is over, we let you rest, let you recover, and then increasingly patients are placed on some form of a continuous maintenance therapy. And again, that depends a little bit on your risk categorization. So whether it's standard risk myeloma, you don't have a high, you're a lower stage, or you don't have the high risk cytogenetics, then sometimes you would be placed on lenalidomide or Revlimid maintenance. And then if you're much higher risk, then you may be considered to be placed on Velcade maintenance, which again is that same drug you got up there, or an oral equivalent of it. All right. So as I mentioned, transplant eligibility is it's a heterogeneous process, and a lot of different factors go into it. So often, we look at what the patient's functional status is. Are they fit? Are they healthy? Do they have lots of other health issues? And then we also sometimes will consider the disease a little bit as well. So, if you're young, fit, don't have a lot of other health issues, your heart works fine, and your myeloma is very aggressive, we'll certainly be considering you for a transplant. On the other hand, if you're much older, and again, the age cutoffs are somewhat arbitrary, because at least in Hamilton, we will easily transplant up to the age of 75 if you're healthy and fit. But if you're older, have a lot of health issues, and we think that the toxicity from transplant is going to be a lot more than the benefit, then we will often not do it. But a lot of this eligibility, again, is determined both by the transplant center, but also in consultation with your primary oncologist. Because having worked at, Hamilton, for example, is a transplant center, I may see a patient from St. Catharines or Burlington for a couple of minutes, but really it's going to be the primary oncologist over there who may know you the best and be able to advocate for you. So really it's a relationship that the transplant center has with the primary oncology centers in order to decide the transplant eligibility. The one other couple of things I wanted to just talk about transplant is that, when people think of the word transplant, they think of all sorts of things. And it's just important to realize that there are different types of transplants out there. So a patient with something called acute myeloid leukemia, for example, will not have the same type of transplant that a patient with myeloma will have. So autologous stem cell transplant is what's used for multiple myeloma, and it's used by taking out your own stem cells, giving you chemotherapy, and then putting those own stem cells back in you. So it's just important to remember that there's different types of transplants out there. Stem cells, again, just a brief thought about stem cells is that, you'll hear that word autologous stem cell transplant. The stem cells are being taken out. So what are these stem cells? So stem cells are the precursors that help each of these cells develop. So the stem cells develop into all of the cells that we absolutely need to live a good, healthy life. And so part of what a bone marrow transplant is doing is collecting those stem cells from you, giving you high dose chemotherapy, and then putting those stem cells back in you to help your bone marrow recover and for all of these cells to form and help you lead, help you fight infections, help you give the energy you need, and help you clot if you were to bleed. And we're not going to go much more into stem cell transplant because it's an entirely separate talk, and some of this information is available on the Myeloma Canada website. There's handouts around that as well. And again, your patient support groups are fantastic avenues to learn more about this because you've had a diagnosis of myeloma or know someone who's had myeloma, and that's already a lot to just wrap around your head. And then I find that the stem cell transplant really creeps up and you've not even had time to really process a lot of the initial diagnosis. And certainly there's a whole host of new information to really process. So there's lots of resources out there, and I would encourage patients to really refer to them because I do think they're quite helpful. So in terms of patients who are not transplant eligible, and to be honest, that's probably the bulk of patients because myeloma is a disease of older patients. So just by that fact alone, there's going to be a number of patients that are transplant ineligible. And the treatment options for those patients have really exploded in the past few years. So a number of years ago, the only two drugs that we could use for transplant ineligible patients would include Cyborg-D, which is the same as that backbone used in the transplant arm, but we would use it for a number of cycles, or we would use a drug called VMP, and that's it. And we would really only have these two major options. In the last few years, we now have access to what we call Revlimid and dexamethasone, and that's been a huge game changer. And now most recently, we're also potentially able to combine that into a triplet regimen. And what I mean by triplet is that there's 3 drugs that are included in that regimen. And I think over the next few years, we're really excited about having some daratumumab-based regimens enter into this space as well. They already are used for relapsed myeloma, but there's been some pivotal trials in transplant ineligible setting, and we hope that in the next few years we will have access to these drugs for this patient population in the upfront setting. All right, so the next part is what to expect. Now, I've given you a lot of information. And so I'll pass it over to Wendy to really just talk about some of the discussion points that you may want to think of as you come to your first appointment.
Hi everybody, I'm Wendy Bursey. I'm a registered nurse at the Juravinski Cancer Center. So some of the discussion points that we're going to go over are talking about your first appointment, which is always a very anxiety-filled appointment coming to the Cancer Centre. Some of your treatment options in your first chemo session, which is also very stressful. Finding out your stage and genetics, your response to treatment, and some of the supportive care options available, and where you go to get some help. So at your first appointment, you know, what are your expectations at your first appointment coming there? What do you expect from that first appointment? It's always good to have somebody with you during this time of, right now you're not always able to bring someone with you. It's always good to be able to have a phone with you so you can have someone at least virtually to dial in with you. At that appointment, you'll probably have a bone marrow biopsy done that will help to make some of that confirmation of your diagnosis that Dr. Mian has referred to earlier. And you'll also have some blood work done. And you'll get to meet your team. That will be very important to you all the way through. And you'll get to know your team very, very well because you'll be seeing a lot of them. You'll also have some imaging on that appointment, probably. You'll have an X-ray, although some centers may do a CT or MRI. There may be some people who present at their first appointment who are perhaps a bit more unwell and may need some urgent radiation, may need admission to hospital, or may urgently need some dialysis. And how do you keep track of everything? There's so much information coming at you. It's really important to have some format that you keep track of all this information. So get a binder that you keep track of everything. And bring that with you every time you come to your appointment to track all of that information. Track your medications, your blood work, your questions that you want to ask your clinicians when you're there, and keep track of the answers.
Perfect. Thank you, Wendy. And I think, you know, Wendy's brought up a lot of really fantastic points because that first appointment is just so overwhelming. And I find that, you know, as the physician, I'm concentrated on, okay, doing the bone marrow and figuring out, making sure all the blood tests are ordered. And it's really the combination of both myself and Wendy that I think are able to balance each other and make sure that we're providing with the best care. So, you know, as I'm running off to gather the supply for the bone marrow, Wendy's making sure that you're comfortable, that your questions are answered, that before you leave, you know what my name is and how to contact us if you get into trouble. And I think just to stress again on the point of the importance of that long-term and great relationship with your primary oncology team is really important because myeloma is really a not curable malignancy. So there's a really longitudinal relationship that needs to develop. So the first appointment is crazy and chaotic, and you know, hopefully, your healthcare team can make it as comfortable as potentially possible. And just remember that you know you might be hearing a lot of information, but we're going to see you again and again, and there's lots of opportunities to go over all of that information again and make sure that you understand all of it. So thank you, Wendy. And so, you know, again, we've talked a little bit about some of this, but some of the treatment options. So again, transplant versus no transplant, oral versus intravenous chemo. And again, the number of visits, the parking and the cost. And again, those are things, to be honest, sometimes we don't even think about, but add a substantial burden to patients. And Wendy brought up this great point of who will bring you. So given COVID and all, and the fact that we're not allowed visitors at the moment, a apart from that, having a person who can be with you is really helpful, because having, you know, 2 sets of ears and 2 individuals listening to all information is much better. A lot of the regimen side effects sometimes are presented quite quickly as well, and again, they may require repeat conversations. And I know Wendy always ensures that patients leave with physical handouts of some of these side effects that, you know, I will just tell them about. The idea about what second line treatment options and eligibility are probably more factors that play into physicians' minds rather than patients' minds. And I think that's probably the right way to do it, because there's certain regimens that you can only use once but not subsequently, but that landscape is constantly changing. So I think probably not worrying about it from a patient perspective too much is a better approach. All right. So that first chemo session, and Wendy, please join in at any point if you'd like to, because I know Wendy has been a chemo nurse. So, you know, when you're first getting your chemo, where are you showing up? And so often we actually have to walk our patients to the chemo suite, because we've given you a wealth of information. And the last thing that you really cannot do is walk through the hospital hallways to find that chemo room. And so, you know, side effects around nausea, vomiting, stomach upset, the hair loss. And again, Wendy talked about it. How will you keep a track of your pills? Who will help you? How will you keep a track of your side effects? So having some form of a method around that is really useful. And a lot of these side effects, you know, if you're, sorry, go ahead, Wendy.
No, I think the big thing is it's really, really important to keep in touch with your team and let your team know if all of this is overwhelming. If it's overwhelming to keep track of your pills, if just all of this is so overwhelming, and your team can find ways to troubleshoot through things and help you, but it's really so important to communicate that to your team and don't let it keep going that you're having a hard time.
Thanks, Wendy. I think you're entirely right, and it's a fantastic point. And I think even in terms of some of the side effects, you know, Wendy will tell you that we want you to call in when you have side effects. We don't want you to wait till your next appointment, because a lot of these side effects can be titrated, or we can give you the appropriate prophylactic medication. So it's just about knowing and making sure that you have the appropriate contact information around that. Thanks, Wendy. That was a great point. And so some of these side effects of treatment, again, you know, they're very specific, and I think this is not meant to be an exhaustive list, because each class of drugs will have different side effects. So steroids, you know, if patients have a high blood sugar or a diabetes to begin with, can cause problems. Some alkylating agents can cause blood counts to go down. The immunomodulatory drugs called Revlimid and pomalidomide require a much longer assessment and you know, forms to be filled out, and require you to be on some form of aspirin or a drug similar to it. Proteasome inhibitors cause a lot of neuropathy, and we always need to make sure that you are receiving something to ensure that shingles doesn't reactivate. And these monoclonal antibodies sometimes can cause infusion reactions. So lots of different side effects happening. But as Wendy said, some of them can really, once we know about them, we can work around it. So, you know, if you're having significant diarrhea from these immunomodulatory drugs, give us a call. Wendy will problem solve it with you. She's seen a lot of them and knows how to do that. Similarly, with proteasome inhibitors, if you're developing neuropathy, we want to know about it. And it's really important for us to know about it, because again, some of these side effects may not be reversible, and we want to catch them in time. And so, you know, the last part and I briefly already talked about it, finding your stage in genetics. The landscape in this, again, is really changing, but finding out your cytogenetics would often take a number of weeks, and so we may not have that information available to us right up front. All right, with regards to response to treatment, so once you've started treatment, we'll be measuring usually response to a variety of blood tests and looking at if that M protein went down by 50%, by 90%, is there no plasma cells at all? And again, there's different ways of assessing response for myeloma. And so supportive care, again, is a really important one. Making sure that you have good diet and exercise, that there's that treatment. If you're having any bone pain, we want to know about it. Having infection prevention, blood clot prevention, shingles prevention, anemia. Again, there's a whole host of supportive things that we want to make sure that we keep a track of. And again, for the sake of time, I'm going to probably just go through some of these slides slightly faster. But bone disease, again, can affect a lot of patients. So it's important for us to know if you're having any pain. A lot of times we will be using what we call bisphosphonates, which are bone protecting medication. And eventually, patients may need something called kyphoplasty, where we actually someone needs to fix fractures, or they may need radiation as well. So again, this is all part of that supportive care around myeloma. Just treating with drugs alone is not going to be enough to ensure that you have a good quality of life. We want to make sure that we're tackling myeloma at every angle. Similarly, it's really important that if you are especially on Revlimid or pomalidomide, that we're decreasing your risk of blood clots, which those drugs are associated with, and that you're on appropriate prophylactic treatment for that. Again, infection is a huge risk factor, especially in newly diagnosed patients. So sometimes we may be considering antiviral treatments depending on the type of regimen you're on. You want to make sure that all your vaccinations are up to date. There may be a role for some prophylactic antibiotics in certain cases, and then if you get lots of infections, some select patients may be placed on immunoglobulins as well. Low hemoglobin, again, you may need transfusion support as well. For that, in order to ensure that you have enough, your hemoglobin is high enough and that you have good energy, and really rarely will we use additional agents which help stimulate your kidneys to produce the red blood cells. And so with this, I'm going to pass it over to Wendy and talk about where do you get the help? What resources? And all of this is overwhelming. And Wendy, what are your thoughts on where should patients turn to when so much is happening at the time of diagnosis?
Well, Myeloma Canada is an amazing organization and has provided a lot of support for our patients, along with the local support groups. If there's a myeloma support group in your area, reach out to that support group, and you can find all the support groups through the Myeloma Canada website, as well as the International Myeloma Foundation, the Canadian Cancer Society, and the Patient Power, and the website is here, and patient resource centers. You may have a library at your local cancer center as well.
Perfect.
And
Thank
again,
you
your primary team is a great resource as well.
Perfect. Thank you, Wendy. That's incredibly helpful. And then before we stop for questions, Wendy, do you think there's anything else that you would want to mention that I may have missed out on?
Just going back to really encouraging people to be your own advocate and try to have a way of organizing your information, and have yourself organized with either a binder for your information that comes back and forth with you, especially during this time. Be kind to yourself, be good to yourself. Everybody needs a little bit of special attention right now.
Perfect. Thank you so much. And with that, I think both Wendy and I are extremely grateful that we were able to share this information with you. And thank you for taking out the time to join us today for this webinar. And we'd be happy to answer any questions.
Thank you, Dr. Mian and Wendy. As I mentioned, lots of information, and so we'll go through a few of questions that we got today, just to expand a little bit on what Wendy said at the end there, about being able to keep track of your information. And so, Myeloma Canada do have some tools to help with that, such as the Myeloma Monitor. So that's a computer-based application that can help you keep track of your medications and your quality of life, among other things. And so you can find that on our website. The other thing is, if we also have educational publications that might be helpful, as well as, if you're a caregiver, or if you're lucky enough to have a caregiver, we have a new handbook for caregivers, which really also explains a lot on how on how you can help keep track of things like that. Now, so let's get into the questions. And so we got quite a few. So the first one that I got here has to do with tandem transplant and high-risk disease. And so would a tandem transplant potentially be considered for someone that has deletion 13?
So right now, I mean, specifically for deletion 13, we would often not be considering it. For tandem transplant, there's lots of different criterias, and to be honest, there's a wide heterogeneity across Canada. So often we would consider it in someone who has conventional high risk cytogenetics, so translocation 414 or 17p, or someone who's really not had such a good response to their myeloma treatment. So, we gave you the 4 cycles of Cyborg-D and you didn't get as good of a response as we wanted you to. So there's maybe some considerations around that. And then there's other very aggressive features of myeloma, such as patients who present with a plasma cell leukemia, where regardless of what your cytogenetic says, or lots of extramedullary disease where, even if I don't pick up the fact that you have high risk disease, clinically I know that you have high risk disease. So there may be some individual considerations around that as well. But the guidelines for tandem transplants vary across the country. So you'd have to check with your institution what specific cytogenetic markers they may be using for that.
Thank you. So with regards to transplant, most people, or the majority of people who do have transplants, they'll only get a maximum of 2 transplants. Why is that? Why can't we do 3 or 4 transplants?
You definitely don't want 3 or 4 transplants. And the reason actually behind that is that every time we do a transplant, we give you high dose chemotherapy. And every time we give you high dose chemotherapy, it actually puts you at risk for other types of cancers in the future as well. And it can affect the way your bone marrow may function in the long term. And we know that, sure, we're willing to take that risk once, we're willing to take that risk twice, but probably more than 2 or 3 times, there's a high risk of developing secondary cancers of the bone marrow in the future. So that's one reason not to do it. The second reason is that every time we do a second transplant, you probably only get half the time you got out of your first transplant. So the actual benefit of the transplant actually goes down as well, and the side effect profile comes up. So really across the world, there's no place that would probably do more than a tandem and a salvage at most in this setting, because again, if your first transplant gave you 4 years, your second will give you 2, and then we probably don't do a transplant. The toxicity is not worth it if it's not going to give you a good progression-free survival.
Thanks, Dr. Mian. Since we're talking about transplant, I'll just go through the transplant questions that I have, and then we'll move on to the other questions that are not related to transplant. And so this one has to do with it's COVID-19 time right now, and we're all living through, and so there's definitely been some changes that have occurred. And so this question has to do with someone who due to COVID-19, getting more cycles of the chemotherapy of the Cyborg-D at the beginning. And so the question is, does this pose a serious health threat, or should there be any concern of receiving more cycles due to the COVID-19? And I guess a sub question to that is, are we still using the same CyBOR-D as induction, or because of COVID-19, is that changing a little bit right now?
Okay, so complex questions, but great questions. So with COVID-19, yes, you are correct. Unfortunately, a lot of transplant programs across the country had to pause to ensure that we weren't putting our patients at increased risk for transplants during the time of transplant, especially for myeloma, where the transplant's not necessarily done for a cure, but more done to, improve the time you stay in remission. There was a decision made really across the country and across the entire world for the most part. In the United States, if you look at all across Europe, transplants were halted. And so little by little, I do think the transplant program across the country will open up. I think all of those patients who've been paused at this time, the eventual plan will be, I believe, again, you'll have to talk to your specific physicians, will be to go ahead with transplant at some point down the road. Now, for the most part, we are continuing to use CyBOR-D, and the reason is because we know that we can do more cycles of CyBOR-D, right? Because in transplant ineligible patients, we easily use up to eight to 9 cycles of CyBOR-D, and patients do okay with it. And we know that it's not going to affect your ability to harvest the stem cells later on. So for the timing, we've just continued on CyBOR-D because we know it's safe and it's not going to affect subsequent drug eligibility or our ability to do a transplant. Having said that, if you are starting to develop side effects with additional CyBOR-D, so that would mean you're starting to develop neuropathy. Some of those things happen the more you get exposed to a drug. So if you're starting to develop some of those side effects, you probably do need to make sure that your physicians know about it, because that may affect, when you should be transplanted or how long you can stay on this regimen. Now, to answer the second question about what type of induction regimen we're going to be using at this time, rapidly changing and again very heterogeneous across Ontario and Canada. So most places are continuing with CyBOR-D. There's certain places in Toronto where they're unable to give the bortezomib that have switched over to a drug called ixazomib. Certain places may switch over to Revlimid-based regimens as well. So there's a lot of variability based upon where you live and what your chemo suite capability is. I have to say Cancer Care Ontario has been fantastic, and Myeloma Canada has been fantastic in advocating for their patients at this time. So we have a little bit more access to drugs than we usually do, which has been helpful. But things are constantly changing and are in a lot of influx. And I haven't talked enough about COVID at all in this talk, so it's a good time to pause and say this is a hard time to have myeloma, and an even harder time to have myeloma when in the time of COVID. So the importance of constant communication with your healthcare team is even more important at this time when there's two very separate processes going on.
Thanks, that was a great answer. So sticking with transplant, how long after a transplant do we know that it was successful or not?
So often success means different things, because I showed you what the response criteria was. So success often just means to ensure that your disease doesn't progress. So often, we measure your blood tests at about 3 months post-transplant, and we hope that they've come down or at least have not increased since pre-transplant. But then a lot of you may also be placed on a pill called Revlimid or some form of a maintenance pill. And that actually can further deepen your response. And it's all really considered part of the one package. So success for transplant, often we'll measure it at 3 months after the transplant, and then at 1 year again, although you get monthly blood tests, because that response will deepen over time.
Thank you. So the last one on last question on transplant, or not transplant actually. So the people who are not eligible for a transplant and they get the other regimens, we did mention that transplant is the best option right now for newly diagnosed patients. And so the regimens that people are getting for transplant ineligible, how do they compare to something like transplant?
So it's a great question. I think that, you know, overall, we do know that transplant probably gives you a longer time with the disease being in remission. Things like cyborg-D, VMP probably gave you less than half the time compared to a transplant approach, and then you would have to go on to a next line regimen. But I think the game is changing a little bit. And the reason I say that is a lot of the newer drugs, like the triplet of Revlimid, Velcade, and dexamethasone, and hopefully in the future things like daratumumab, our transplant ineligible regimens are becoming fantastic. So, you know, transplant is certainly a good avenue for disease control, but if you're transplant ineligible, I would say that there's actually really great treatment options. And although they may not keep your myeloma in remission for as long as a transplant approach, when the myeloma starts to come back, again, you'll have lots and lots of treatment options. So I think some of the biggest breakthroughs that are being made in terms of drug development are really in that transplant ineligible space. So lots of optimism around that.
That's good to hear. Absolutely. Um, Fish testing, is that standard throughout Canada? Do you know if basically all the centers have that, or or not every center has access to that type of testing?
To my knowledge, most centers across Canada have access to it. What they actually test in their fish panel may be slightly different. So, for example, Princess Margaret Hospital has a much more lengthy panel than a place like Hamilton. But some of those prognostic markers, you know, the lengthy panels have in the moment, we don't know how to really interpret them. So I would say most places in Canada have the basic fish panel, which we use to stage you, and that's probably sufficient for now.
Thank you. Someone here is asking, what's the difference between a PET scan and a CT scan?
So a CT scan is just when we're looking for fractures, or bony lesions, and it's much better than a regular x-ray for showing us that. So, you know, if you're having a lot of bony pain and your x-rays are negative and I can't quite figure out if you have a fracture, I may order a CT of that area. A PET scan is actually used for very different reasons. A PET scan, and it's often a PET CT, so it includes two modalities together, is when they actually give you a tracer molecule and they inject it, and that tracer molecule will go into the places where there's active myeloma activity. So a PET scan right now is used for patients where, let's say, if we have no way of measuring myeloma activity in their blood, so they're considered non-secretory myeloma. So I actually don't know how you're responding to the drug because I have no way of measuring it and I can't keep doing bone marrows. So a PET scan might be good for that. Another time when a PET scan is used is if we're looking for disease that's outside of the bone marrow. So, you know, you have a myeloma spot that's at an unconventional place, and so a PET scan, it will actually light up where we think the myeloma cells are being most active. So there's slightly different scans and used for different approaches. A PET scan has to be ordered, you know, at specific centers, and it is not routinely done for all patients with myeloma.
Thank you. So I have three more questions. Are we still okay with time? I know we're about 3 minutes over time, but
I'm totally
we?
okay.
Okay, great. So thank you. So bone marrow biopsy. So you know, are they? I think you mentioned that they were essential and that you know there's no way around it. And so is this true? Is this going to be true forever, or can at some point one day bone marrow biopsy not be used?
I know. I think about this all the time because it seems such an archaic method. Like the world has moved on and we do all these fancy tests, but to get to a diagnosis of myeloma, I still need to do a bone marrow. So as of right now, definitely that's the answer. I think there's been a lot of progress that is being made into look at whether or not we can detect some of these cells or certain markers through a regular blood test. But these are still far away and they're still only being done in research laboratories. So unfortunately, I think for the time being, you're stuck with bone marrows. The one point I do want to add in is that, as part of clinical trials, for example, you may need lots of bone marrows. But every time, if you're having repeated bone marrows, I do think it's important for you to understand why they're being done. And so some of them may be being done for response assessment, some of them may be being done to relook at your cytogenetics, because you want to make sure that you are getting the information you want out of a bone marrow as well. And if you think that a bone marrow procedure is not adding much more to what you already know, then that's a discussion you need to have with your physicians as well. I would say the first one is essentially important because I can't actually diagnose you with myeloma without doing a bone marrow. But I think the subsequent ones do require a little bit more thought.
Okay, and thank you. And so that kind of goes into the next question, because you did mention clinical trials, and I know we did briefly mention clinical trials in the presentation, but didn't really go into it. And so clinical trials. So this one has to do, well, clinical trials. Are clinical trials available just for people who are relapsed, or are they also available for people who are newly diagnosed? And so at what point, I guess, in the whole treatment journey with myeloma should clinical trials be considered?
So I would say probably at every point if it's possible. So, usually in the relapse refractory form, there's often more clinical trials available because we don't have enough conventional agents at that time. Clinical trials, I would really encourage people to always think about them because they often will offer you an opportunity to potentially access a drug that we don't have access to through regular routes. And some of those drugs will end up being, really important drugs for myeloma. Clinical trials are also important because if patients didn't enroll in clinical trials, well, then there would be no way of knowing which drugs are better or not. So at each point, if there's an available clinical trial, I do think that patients should be presented that clinical trial and should think about it. And again, I'm a huge advocate for ensuring that older adults also get an opportunity to participate in clinical trials because again, they may benefit most from some of these newer drugs. There are clinical trials that will happen in Canada, hopefully next year, for newly diagnosed, in second line treatment, in third line treatment. So it just depends on where you live. Some of the clinical trials are sponsored by pharmaceutical agents, which are, trying out a novel agent, which they think works really well. And some of them are done through the large cooperative groups, so such as the Myeloma Canada Research Network is doing a number of large clinical trials over the next years, and some of you may be presented with the opportunity to participate in them. So thank you for bringing up that question. It's a great question, and always ask your primary care team if there are clinical trials available.
Thank you. And with that, it wouldn't be a webinar without talking about CAR T cell therapies. And so we did get a question on CAR T cell therapy, and basically the question is, what's the current treatment landscape in Canada when it comes to CAR T? So I mean, I just want to make a comment here because I do get this question a lot. A lot of when someone is newly diagnosed, you do some research online and you see, oh, CAR T cell therapy. This sounds like this is an amazing new treatment, and how can I get it? And a lot of the times I have to tell the people who contact me that right now CAR T cell therapy it's not available for people who are newly diagnosed. And so what in what setting is CAR T cell therapy available in Canada, and where?
Sure. So I think with CAR T therapy, again, there's a lot of buzz around it, and a lot of us are excited about the potential it holds. But I want to pause here and say the potential it holds. Because right now, we actually, a lot of the trials that have been presented for CAR T therapy are presented in patients that have received multiple lines of treatment. And although most of those ones still had a response, the myeloma always came back. So CAR T therapy is, again, one additional treatment option, but it's, as far as we know, it's not a cure for myeloma. I think the CAR-T technology is still being refined and worked further. There will potentially be some clinical trials available at very certain institutions because, again, it requires very specific organizational structure, right? So CAR-T therapy is not going to happen at a small community hospital where you can get your bortezomib. It will probably only happen at the bigger transplant centers just because of all of the things it requires. So there are some small CAR-T trials that are starting to happen in Canada, and hopefully over the next year with pharmaceutical industry, there will be some additional trials available. But I would say, especially in a newly diagnosed setting, it's far from, just how Gabrielle pointed out, far from being a treatment option in that setting right now.
Thanks, Dr. Mian. And so we have just one last question that just came in. And so we recently found out the news, I think it was this weekend, that in the United States, the FDA approved the subcutaneous use, so the injection of daratumumab. And we know that right now in Canada, this type of regimen is only available in a clinical trial setting. So can you just comment on if we can expect this in the near future in Canada, and how is the subcutaneous version of this drug doing compared to the infusion type, I guess,
So I
regimen?
think, very similar side effect profile, very safe. In Canada, daratumumab subcutaneously has already been given through a clinical trial with Myeloma Canada Research Network, and some of the patients may have participated in that. I think that we really hope we get it. We don't see any downside at all and only upside of getting it, because it's going to save you a lot of time coming into the chemo suite, and it will be much faster. So I think that as long as it doesn't cost the government anymore, I think that there will be a lot of enthusiasm for getting it approved in Canada. But I don't know
Awesome.
when yet.
Okay. Well, we'll get on that and try to find out. So with that, thank you, Dr. Mian and Wendy, for taking the time out of your busy schedules to come here this afternoon to present for us. I think it was very useful. This webinar was recorded, so for anybody, any future people who are interested, newly diagnosed people can come in and reference it, and it'll be a great tool for them. Before I let everyone go, just a reminder that on Thursday we have our Myeloma Canada Patient Advisory Council webinar, and so you can get to know them a little bit. David, Phil, Susan, Manon, Glenn, Deb, and David McConkey will be there. And I hope to see you there, and I know that they hope to see you there as well. And so thanks again. I wish you a great rest of your afternoon and a great evening, and hope to have you on a future webinar.
Great, and thank you everybody so much for joining in today. I would have been great to do this in person, but I hope everyone's staying safe and healthy. Take care.
Thank you. Bye-bye.
Bye.